Laura, thank you so much. I am just here to briefly introduce myself and to thank all of you for being here today. I am the Population Health Management Division Chief at the department, which means that I help to support the good work of Yoshi, Laura, and the full service. And I'm also the executive sponsor for the PHM service, or newly christened Medi-Cal Connect. It's terrific to have each one of you here, and Yoshi and Laura are going to go through some content and elicit your feedback, and we're really happy that you were able to join. We invite you to participate fulsomely and in fact expect it. With that, Yoshi, why don't I pass the baton to you?
Got the baton. All right.
Love it.
Good afternoon, everybody. Welcome. And thank you so much for your time. I know you're all busy out there spread across the state. My name is Yoshi Lang. I am a family physician and one of the technical titles, Medical Consultant 2 in Quality and Population Health Management. But with the PHM service, now Medi-Cal Connect, I'm the project executive. And Dr. Laura Miller is our assistant project executive. And she'll do her own intro in several minutes. I'm going to basically do the first half and then pass the baton to Laura. So if we go to our objectives, we are really excited to have you all here because this is actually the first time in about a year that as a department, we've kind of come to we'll call it like a semi-public forum to all of you who are going to get basically an early look at what we're building. So today, all of you are representing various entities, partners, stakeholders across the state who will have access to Medi-Cal Connect, minus the Medi-Cal plans because they had their own separate webinar. But today, we want you to understand what our goals are of what we're creating, and the functions that it will include, and then your roles and responsibilities as early adopters. And then we'll talk about next steps. And then while we're doing this, we do welcome any real-time feedback. You can put that in the chat or ask questions about it. And then one of us, including our partners, our vendor partners, Gainwell team, we'll answer those questions in the chat, and then hopefully we'll have time at the end. I think we'll almost certainly have time at the end to do some live Q&A, and then there's also going to be polling. So next slide is the agenda, which is largely just kind of a reiteration of our objectives. So we'll just keep jumping ahead to the next one. All right, so vision, goals, objectives. What is this thing? And we've been playing around with taglines and elevator pitches. We do have a comms vendor will come on in a couple months, but until then, right, it's just been our homegrown DHCS folks working on the messaging. But what the tagline that we are liking right now is something like this. We are unifying data from our trusted partners across the state to close gaps in services and improve lives. And then if I were to take it a level deeper, if I were trying to explain to family or friends, what is this thing you're building, Yoshi? I would say it like this. We are gathering data from various places, putting it all together, and then making it available to all those entities and members directly so that they can see what are the gaps in services and improve health. Okay, so I wanted to say it that way first. And then the next slide gets a little more technical. So our vision statement here is that we're going to provide this data-driven business solution to support whole person care by integrating information from our trusted partners to support population health functions and allow for multi-party data access and sharing to all of you. And then we think about this in 4 buckets of objectives. First and foremost being member experience. So this will look like for members, it will likely be an app or a web portal, and this is going to be a user-friendly tool that allows them to access key information allows them to understand their benefits, their likely services that they're eligible for, and then streamline access to those services. Second bucket, whole person care, which is relevant to all of you out there. Improving the health of Medi-Cal members by leveraging integrated data. So we're going to be able to address risks, unmet needs, and empowering various providers with actionable insights. And I like to use the example of WIC and CalFresh because it's one of the easiest sort of use cases to understand. When we think about member experience and what that would look like, it would be a member saying, oh, I see here I have Medi-Cal, I'm enrolled in Medi-Cal, I have a dental plan, and oh, look over here, it looks like I would likely qualify for WIC and CalFresh, and here's the link where I go sign up. For a service provider under this bucket number 2, whole person care, a care manager, for example, would be able to see their own view into this and see, oh, this client I'm helping likely qualifies for WIC and CalFresh. Let me go sign them up for this. Third bucket, population level insights. So this is really exciting because we've never been able to do this before at a state level, where we'll have data from across the state, dashboards that will allow us to see population level health trends across the state. And you all will have a view into these same dashboards and analytics. Then the fourth bucket is to inform policymaking. So this will enable us as the department to oversee policymaking, to make better decisions about our programs that are going to drive health equity and improve care. And then I'll explain what the first 5 releases will look like. And also want to say that this thing is going to continually evolve. I hope it's clear that there's a ton of potential here. And in the initial 5 releases, we're going to make a thing that will hopefully be very helpful. And then I think the functionality will continue to expand after that. So next slide. Raise your hand if you've heard of CalAIM. Just kidding. So I think everyone is familiar, at least somewhat familiar with CalAIM, and that the PHM program is really a cornerstone of CalAIM. And so I think of 2 sides of a coin, and one side of the coin, big side of the coin, is PHM program. And that is largely directed at the Medi-Cal health plans, managed care Medi-Cal plans. So enhanced care management, transitional care services, those are all under PHM program, and that's already launched. And then the other side of the coin, Medi-Cal Connect, also previously known as a PHM service, is going to be our data backbone that supports everything we're trying to do and implement in the PHM vision. And it actually goes beyond just our PHM division and the PHM program, because the service will be getting data from a broader set of entities out there. So that's why that second box on the right side says includes programs and infrastructure that goes beyond MCPs. And then select components will be available to DHCS in 2024. We're going to show you the rough timeline, and then it'll expand to a broader audience, which is all of you. Okay, so next slide. More overview. And here's the timeline on the next slide. So Q3 coming up very soon. A limited set of DHCS users will get their hands on this. So we've already been doing configuration of dashboards with our DHCS SMEs, small group of DHCS SMEs. And so they'll start using it Q3, and then Q4, we're going to have all the DHCS users using Medi-Cal Connect and those dashboards. So this was right, number 3 of the objectives is being able to have population level insights And this will allow us to see, for example, going back to WIC and CalFresh, are there regions that are doing well in terms of WIC and CalFresh enrollment? Are there certain plans that are doing better or worse with WIC CalFresh enrollment? As an example of something that we'll be able to see with those dashboards. Then release 3 is when the plans, both full scope Medi-Cal managed care plans will get this, and the mental health plans will get this, and state partners and agencies will get access to this. And that's in 2025. And then third quarter 2025 is for many of you. So here we've listed local county partners, PHM program services, supports healthcare delivery partners. So I think a lot about enhanced care managers being part of this group, and then other delivery systems, tribal partners. So this is when an enhanced care manager, for example, will get this view into Medi-Cal Connect, where they'll have their list of clients and be able to see things like this person likely needs WIC, CalFresh, I'm going to sign them up. They would be able to, hopefully, the plan is that they'll be able to do screenings and assessments with their individual folks that they're helping, for example, and be able to message with the plans. There will be a messaging capability also within this portal. So that's the whole person care functionality. And then there will also be those same dashboards, basically like your own versions of these dashboards that we've already been implementing through release 1, 2, 3. And then last and most important are members, early 2026. This was a very intentional decision. We knew that we're only going to have one chance with members to get this right. So we wanted to make that the final release and then start engaging with members and advocacy groups early on so that we have plenty of runway to make something that's going to be as helpful as possible to members. So I described some of those functionalities for members already, and we can talk about that more later if we have time. Okay, let's go to the next slide. So I know it has 1, 2, 3 here about our overview of capabilities. I actually think of it as 1 and then 3 and then 2. I'll explain why. So number 1 is integrating data from DHCS and other sources. And you can see quite a few examples here, right? So this is going to be physical, behavioral health data, social services, dental. The list is quite extensive. And this, to be honest, has been one of the most challenging parts of this project, is just trying to get data from all these different sources, but we're making headway. So first, getting that data. Then we have to make that data available, which is really what number 3 is. And I've already listed, right, the users of the service, which is all of you. And then we make that data actionable, functional, which is number 2. So that's how we're going to support population health functions. We're going to be able to do screenings and assessments, like I mentioned. And then one really important thing about the service is this risk stratification, segmentation, and tiering algorithm, RSST. So for the first time, we will have a statewide risk tiering algorithm, which we've never had before. And this will enable us to compare apples to apples risk population for one health plan versus another health plan. And the health plans will be required to use this. Many of them already have their own algorithm, but we welcome them to continue using what they already have, but they must use our RSST algorithm. So another exciting development. Okay. The next slide is really to, again, illustrate what we're doing for members, combining physical health, behavioral health, social services data. So we will have data from the justice system, from HMIS, housing. We will have enhanced care management data. We will have social support data, so things like community supports, And then, of course, health data. We have all the claims and encounters data in the department, and then food, CalFresh, WIC. So these are just examples. This is not a comprehensive, but just to illustrate how we're getting all these pieces of data all to support members. And then when we think about what the member will be able to do in that box in the right-hand side, we want to make this, like I said, easy to use, as helpful as possible to members. We want them to be able to navigate benefits, to close gaps in services. Also, updating contact and demographic information is another key functionality that we will implement as part of the member portal or app. Okay. So we have come up with an aspirational story of what this could look like from a member perspective. So here we have Claudia. She's a 36-year-old mother of 3. She finds it difficult to navigate her benefits. This was something that J.C. Cooper, our former Medicaid director, often pointed out, is that our system is really hard to navigate for members. And so here she begins using it's My Medi-Cal Connect, and that simplifies this process for her of navigating her benefits. And apologies, let me pause there for a second. We generally call it Medi-Cal Connect. For members, it will be My Medi-Cal Connect to differentiate that this is the member-facing portal. So she starts using it. The platform shows her that she's likely eligible for CalFresh and WIC. She sees the links there to apply. Shortly after, Claudia uses Medi-Cal Connect to complete a required health screening from her plan, and it's already pre-populated with data that her plan has. Remember, I said this is aspirational. Then the MCP receives Claudia's results, and she's flagged that she's likely eligible for ECM because of her health conditions, and her housing is unstable. So eventually she gets referral to ECM. The ECM provider sees the assessment prior to contacting Claudia, so that care manager already has the answers to those questions, doesn't have to ask Claudia those questions yet again. Last box here is that now Claudia has CalFresh, WIC, ECM. All of these things improve her family's health, reduce her stress. And then the cherry on top is that the ECM provider also helps her find a primary care physician who's closer to her house and ensures more regular access to healthcare. So I hope that's helpful in kind of illustrating a potential member journey using Medi-Cal Connect, My Medi-Cal Connect. Okay. And the final slide I'm going to share with y'all is just sort of a recap of what, we said the service, what Medi-Cal Connect is. So again, enabling members to effectively assess potential eligibility for services, update demographic and contact information. It will be a centralized repository for all this data that I've been describing. It will guide members towards appropriate health and social service programs that will really impact their lives for the better. Also offering a platform for viewing member care plans and sharing information. Yes, and I meant to touch on that. So another functionality is for you all to be able to view a care plan for an individual member. Of course, this depends on your security access, and I haven't spoken to that, but that is of the utmost important consent and access. And then finally, empowering members to easily access health education materials. That's another potential functionality that we could include. And then it's also important to think about what this Medi-Cal Connect is not. It is not going to be like an EHR, EMR real-time tool. So bear that in mind. And then it's not going to be used for making member patient-related decisions in real time. It also won't be a fully functional care management system. And what I mean by that is like a fully functional care management system could have things like, here's what you do for a patient with diabetes or a patient with asthma. Those protocols that will not have that level of functionality. But I hope that you all are excited for this, like Hope, Laura, and me. And I'm going to hand it off to Laura. Tell our friends a little bit about yourself, Laura, and take it away.
Sure. Excuse me. Thank you so much. Good afternoon. I think I know some of you. My name is Laura Miller. I'm a primary care internal medicine physician. I've been at the department a couple of years after really being deep in the safety net in Alameda County for quite some time. And the service is one of the things that I have the honor of working on. So, and thank you all for being early adopters, for being really a set of actors in our very complicated system who can help us shape the service such that it is really of greatest benefit to you, your organizations, your partner organizations, and of course to members. So I'm going to talk a little bit about what it means to be an early adopter, what we'll be asking of you, and what we will be giving. So hopefully it will be a win-win. So I love this slide. It's sort of a benefit responsibility back and forth, which is great. So in terms for you all, in terms of being early adopters, you'll be able to see Medi-Cal Connect under development and give us feedback. Let us know, are there things that we are missing? Are there functionalities that we don't have now that we need to put on the list for future? You'll have advanced access to the service when it goes live, and you'll really be able to help us, engage with us to inform Medi-Cal Connect and make sure it's really doing the job that we want it to do. On the responsibilities side of life, we're going to ask you to attend 2 to 5 meetings over the next 10 to 20 months. So hopefully not too egregious, although all of us are pretty busy. We'll ask you to make recommendations. Tell us your wish list. Tell us what you think, and then be able to give input on our capabilities and help us identify gaps. So you're really vital, and we appreciate you being able to illuminate the needs of both your organizations and those who are also in your sector. Next slide, please. So this is a timeline, and right now we are at the first open circle here on the arrow. So May 2024, webinar number 1, hooray, we are here. And this lays out the releases that Yoshi went over in terms of how we are releasing the service to different systems, different actors in our ecosystem, interleaved with more webinars, more touch points with you. So by the time we all meet again in Q3 of 24, DHCS will have had its first release, et cetera. And you can see how the webinars march out in relation to the releases. We will also have additional touch points outside of what's shown here. We'll certainly give you invitations 30 days in advance so you can plan. And those other meetings besides webinars will help focus on your feedback, give you status updates, let you know what's happening with configuration, and also to help us identify your distinct needs so that we can adapt as we go along. So hopefully that makes sense. Again, as Yoshi noted, the member release is at the very end, in part because we know that we really need to get that absolutely correct. And just so that you all know, we're really beginning our work on member engagement now, thinking about focus groups, thinking about advisory groups that we can link to. So all of us are thought partners in terms of how we can really improve member experience. So we may be asking you to opine there as well. And certainly don't hold back. If you can articulate member pain points, please. We want to be able to solve a lot of those pain points. So next slide. These are the different kinds of ways we hope to engage you. This webinar is high level, it's a check-in. It's really not a check-in, it's a kickoff. We'll check in later, but right now we're really just doing a very broad brush PHM Medi-Cal Connect 101 so that we get everybody on the same page. There'll be working sessions that are planned to be very collaborative. We'll ask for your help configuring use cases and capabilities for the service. We want to have listening sessions where we really listen to what are the pain points and then take those issues back and think about how we can respond to those needs. We'll also have small group discussions where we sit down and we look through specific feedback and use cases. And we'll also have feedback groups. So a variety of different modalities to really try to understand what does the world look like from your point of view, and how can we have Medi-Cal Connect really respond to areas where you feel a need. Okay, next slide. We said we wanted feedback. We want to really hear from you. So we're going to do some polling. So please pull out your cell phones. There's going to be the ever-present QR code that Vincent is teeing up. Let's see. So we want to hear first about what concerns you have about Medi-Cal Connect. You've heard this, you've probably heard about the service before. What concerns do you have? What might be keeping you up at night? And I do believe that the QR code is up here, tiny, but it seems hopefully will work. So if folks could use that QR code and start putting in free text, what concerns you? And as Samantha noted in the chat, you can either scan the code or navigate to the little site that's there, polev.com. Okay, so we're going to leave a little bit of silence to have people respond to that. So I will watch the clock and be quiet.
And I would also offer that if folks would like to jump in and spontaneously speak to any concerns that they might have, they're more than welcome to do so. And I'm sure Laura will also shift to that once we have more responses in.
I'm actually not sure if we have the ability to unmute folks in the webinar format, but I'll let Sam or Vincent chime in if we're able to.
Yeah, I don't think folks can unmute, but if they want to put questions in the chat, we'll be answering them after the feedback.
Terrific. Thanks, Sam.
That was me setting a 1-minute timer for myself. Do we think things are still flowing, or shall we give it a little more time? Looks like things may be flowing still. I'm sensing some coalescing of issues here. So it looks like it's slowing down a little bit. I'm trying to sort of synthesize as we go through. I see a lot of themes around local social health information exchanges. I know that lingo from Alameda County. Issues around other portals, multiple portals that people need to log into. Issues of will the data be up to date? So I think a lot of those we are working on really articulating how this project relates to the data exchange framework. In a lot of ways, the data exchange framework is really about the scaffolding, if you will, but not the actual getting of the data to a place where people can use it. And that's one of the pieces that we hope the service will solve, getting that data to be more usable. I see issues here around privacy concerns. There's definitely a whole work stream that is involved in the project around consent management. So certainly we have been building and thinking with all of those elements. I think I see the piece about EHR. As planned now, the service will not talk to EHRs. So yes, it will be a separate place. But as with anything, we're hoping that the data will be rich enough and pull from enough sectors such that it will be worth it to go into that separate portal to gain extra information. It really is, what is the activation energy that it takes to get in? And a lot of that is about the richness of the data that will go in.
And we haven't talked about data feeds or APIs, but that is also within scope of the project. So if an organization out there chooses to try to bring an API into their EMR, that may be possible. And then as early adopters, you'll get to weigh in and tell us if that's what you want. So conversation to be continued.
Mm-hmm. I see this question about, would like to know more about what the asks will be of us. I'm not sure who wrote that, so I don't know who exactly the us is. But for those of you on the call and the organizations that you represent, in terms of being an early adopter, the ask is really to be in conversation with us around the service, its characteristics, and what problems you see that it might help you solve. The whole issue of data acquisition, data permissions, data flows, that's not what this particular group is about. Those are other conversations that are happening.
One point about HIEs, SHIEs, is that the service can certainly, well, I should say potentially help with data exchange between counties and other local entities. Yes, there will probably be a data lag. However, if there are no pipes between counties and other local entities, the data could be exchanged through the service. And Gainwell team, feel free to add more nuances there. Let's see, Vincent, is there a way to see all of these? Because we're only seeing, 6 at a time. And then also I know we need to get to the next polling question, but really appreciate everyone sharing all the concerns and all good points.
This point here about our health centers don't have systems to ingest assessments for patients who never come in and therefore have no medical record. I totally get that. I spent 20 years at a federally qualified health center in East Oakland. It's the issue of the people who don't come into your health center. How can you do population management if they don't know? So I totally hear the issue around, like, if you don't have a patient chart, you can't ingest an assessment. But I think we're trying to go a little bit upstream and use the population health management service to help health plans identify those who have not come in, reach out to them, and then get them in. So it's really, let's get them in and get a patient chart started. And then perhaps it will be a care manager in the clinic looking in the service to see what's there in terms of assessments. The ingesting assessments has to do with the talking back and forth with the EHR, that linkage, and that is not in scope. But I think we can get you, one of the goals of the service is to get the patients who don't come in, help them get into the clinic and get started. Should we include some of our front end managers? I think absolutely. I think
love
that is lovely. Yes, please. I know as a, medical director in a clinic, I didn't know what the front office staff knew. So lovely. Really appreciate that.
Hey, Tangerine. I would love to answer your question. We did not elaborate very much on the data exchange framework, but data exchange framework is I would say more focused on policy and procedure. It's not laying down the actual pipes where data will flow through, and the service will do that for Medi-Cal members. However, a DXF data exchange framework applies to the whole state, not just Medi-Cal members. And then the other thing is that data exchange framework and the QHIOs are really focused on point of care, real-time healthcare data, which is not what Medi-Cal Connect is intended to be used for. I hope that helps. And Jessica asking, is this more tailored to CBOs, community-based organizations, over who? I'm not sure. More tailored to CBOs compared to who? I'm not sure. I get the way I would answer that is I would say members, as you remember on the timeline slide, members are highlighted because the focus is really members. But I would say probably the most tailoring that's happening for members is for the plans, because we will configure things specifically for the plans, and then for DHCS users. So I wouldn't say we're going to do a ton that is really specific for CBOs. However, our intention is that CBOs, especially those doing enhanced care management, for example, would be able to use Medi-Cal Connect.
So I think at this point, we're going to move on to our next question. All of these will be captured and we're going to be able to really look at them, see where the themes are, and then begin to address and really leverage your knowledge and expertise to help us solve some of these. So the flip side to what's keeping you up at night is what opportunities can Medi-Cal Connect provide for your group or organization? What excites you about this? Is there a pain point that you can already see that the Medi-Cal Connect might help solve? And so there's the QR code, and I will be quiet for another minute.
Yes, limiting overscreening is a explicit goal of Medi-Cal Connect.
I see it's slowing down a little bit. So I think as I saw these popping through, it was like, y'all are singing my song. Yes, this is why we're doing this. I saw themes of people being able to update their demographic information. When we talk to the health plans, that's one of their most, the things that they're most interested is updated demographic information. Definitely being able to have members need less support in navigation. The folks who can self-serve could self-serve and figure out, how to get what they need. I often think that, our systems are incredibly fractured, and we ask our most vulnerable members to try to manage fractured systems. I should be quiet. Things are still popping.
Yes, we should be able to get you behavioral health data. That is another big goal.
Definitely the access to a universal risk score. That's the RSST that Yoshi was speaking to early. I really appreciate this point. There will have to be a massive communication campaign to have people truly adopt it. Yes, we get that. It has to be good enough that you're willing to remember yet another password or have it written down to be able to go to use it. And we are really thinking about that in terms of communications to incentivize adoption. So we totally get that point, and it's in our sights. It's going to require trust.
I was going to say, and it's also going to require input from all of you so that what we build is so useful that people want to use it. And then, right, in tandem with that, we will be investing in a communications vendor, like I mentioned, who can really help us with some sticky, effective messaging.
Yeah, maybe Vincent, if you could go down to show us the beginning of the pieces that flowed in. We mentioned that piece about limiting overscreening, really recognizing that continually screening around food insecurity, housing insecurity, that can be traumatizing, and we don't want to do that. We want to be able to have care managers come in having some sense of the lay of the land, but not screening from a place of not knowing anything. And again, better reaching patients we've not seen. Exactly. If demographic information is updated, there's risk stratification to understand people's risk, then plans, systems, clinics can outreach and get people in. And the benefits navigation is huge. So I think that those are a lot of them. Yoshi, do you have any more commentary on these?
It's all the same things that we are excited about. So I'm just, I'm having warm fuzzies seeing everything that you all are putting in here.
Yeah.
One thing I saw on the concerns, we don't have to switch the screen, Vincent, but was folks saying something to the effect of, oh, this is another system my staff is going to have to log into. And I have a couple thoughts on that. So the health plans are the only ones required to do something, at least in our current thinking, which is they have to use the RSST algorithm. For everyone else, so all of you are partners out there who are not plans and are members. I'm going to say it again. We just need to make this as useful as possible so that everyone wants to use it either directly in the interface, in their portal for care management capabilities or for dashboard and analytics, or the data we have is so rich and robust that you want the data feed, you want the API. So that's the point I wanted to make.
Absolutely. I think at this point we can flip to our last slide here. Whoops. which is really about addressing any questions that you have. We'll look at what is in the chat and address those. The other thing I want to let you know is that you will be getting an email asking you to register as early adopters. Yes, you have registered for the webinar, but this is a separate process to let us know who in your organization should be your appropriate contacts for our ongoing early adopter engagement. So you will get an email to that effect. Please let us know who from your organization will be in our early adopter cohort. So I see the question from Sabra around the RSST methodology. Yoshi, you may know that better than I.
Yeah, I think definitely methodology we can share, and I'm guessing there will be some interest from various partners out there who want to learn more about how did the state come up with this algorithm. And when we get closer, I think, to release 3 for the plans, we may want to consider a webinar specifically about RSST and the methodology. Our plan is not to provide the raw data that goes into the RSST algorithm, but we can explain like what's the data that's coming in, how did we weigh it, how did we put it into these buckets of physical health versus behavioral health versus underutilization, which is a unique aspect of our algorithm. So quick answer, yes, we should be able to.
And I think one of the things that is so interesting and really crucial about the RSST is that it's pulling from a broad swath of data from multiple sectors. And it really is going to be targeting or looking at and trying to identify underutilization and helping people get to benefits, as opposed to a perhaps more traditional, let's control costs algorithm. Let's find the high utilizers. So I think it's really pretty groundbreaking. I'm looking at please feel free to pop stuff into the chat. We'll try to do our best.
Laura, there's one question that at the top of the chat that wasn't answered yet, so I'll ask it, and then I think that may be our last one we have time for. So it's, can we pull care plans into the member's medical record? And if so, will there be a way to do these downloads in mass, so not just one by one?
Oh, I tried to address that one. The quick answer is probably. But again, we need you to let us know what's going to be the most helpful thing. And if we can provide a data feed with care plans that could then be downloaded into your EMR, I think we can try to do that.
Yeah, and some of that is the fact that you're asking the question may mean that it's important. So that's helping us focus on it. I mean, when I think about that problem, I think, well, we'd have to get all the care plans, right, into our system. So that would mean an effort to have all care plans come in and then figure out a way to download. So
right. So
yeah,
there are definitely policy implications here. I don't anticipate that the state, for example, would require everyone to put their care plans into Medi-Cal Connect. But at a minimum, we're likely going to ask for care manager name, contact information, and so that would be universally shared appropriately. So that's my brief answer for Molly. And then Brandon, we should wrap up. So, we got another one. Okay, we'll
I'll
address
take
these
Brandon's.
2 more questions. Go ahead, Laura.
So, Brandon, it's a great question. How much medical information will be captured? If someone has diabetes, will we see that? Will we see when they were first diagnosed? We're working, one of our really core data sets are claims. So every time the primary care provider, code, the ICD-10 for diabetes, that goes on a claim and that's in there. We may not be able to pin down the date of diagnosis, because even in the medical record, that can be dicey. But we will definitely be able to note diabetes as a condition, multiple other conditions. We won't have up-to-date clinical information. So last A1C, likely not. But diabetes and assigned primary care provider, assigned primary care clinic, that would likely be in there. But it won't be like an EHR where you could go to the lab section and look for the most recent A1C. So that is, it won't serve that purpose. Won't supplant the EHR. Yoshi?
Sabra, yes. I was excited to see Sabra's question, and I was like, yes, this is a kind of another explicit goal of Medi-Cal Connect, is that when someone changes plans, then the appropriate data is shared with their new plan. So, for example, screening and assessments would hopefully be shared. And then, Maisha, I responded to your question. Sorry, that is not in the plan currently to handle closed loop referral tracking.
And then Molly, to your question, where are the care plans coming from? How are they being generated? The answer is wildly multiple and various. Right? Every org, every ECM has a particular care plan modality. So that's something that we're really thinking through as we think about the care management within the service. It may be that getting the exact care plan isn't what's needed, but maybe we just need to have in there the organization and contact number of the ECM provider. So things to be determined. And again, this is where the voice of you all comes in. Like, what does make sense for you? You know, there's both getting in care plans from a multitude of organizations, and then how would it get downloaded? So, and what's the pain point that we're trying to solve, and what are your particular interests there? So it's sort of a squishy answer, Molly, and you know me, and you know I don't like squishy, but here we are. So we'll just have to see.
It's, a fair ways away, right? April next year for plans, and then I believe third quarter for you all. And so we have time, and that's we're gonna get your input.
Yeah.
All right, we should wrap, but this was fantastic. Thank you so much for your input on the polls, the very valid questions, concerns, and the excitement. Appreciate all of that. Thank you so much.
Great. And you will be getting a follow-up email asking you to register to be an early adopter. It's basically we're starting a long-term engagement, and we'd like your positive assent to join us in this journey. So thank you very much.